Hi, this is Duncan Ferguson. In this unit, we'll be talking about OP prime DDD as therapeutic for hyperadrenocorticism. And a little bit of background, most of our diseases associated with hyperadrenocorticism are pituitary-dependent hyperadrenocorticism, but this is a drug that also can get at direct issues with the adrenal glands, such as metastatic carcinoma or adrenal adenomas. So let's start with the old standby, OP prime DDD. As I said, it's a derivative, as you can see over here, it's a derivative of, it's a hydrochlorine derivative of DDT, and actually was a byproduct that was made when DDT was being synthesized, and it was determined in some experiments to be adrenolytic in the dog. It's mainly used in human medicine for adrenal cancers, and not in any other way. So how does it work? Basically, as I said, here's the histology on the left of the cartoon of this histology on the left of the adrenal cortex, and we have the zona fasciculata and reticularis that seems to be mainly affected by this. It leads to selective necrosis of these areas. And therefore, because of that, the zona glomerulosa seems to be less affected, and unless really high doses are used, and therefore we see very little electrolyte changes under most circumstances. Some practical details about OP prime DDD. Basically, it has poor oral absorption, what is enhanced with food. That's probably due to its lipophilicity. It's distributed into every tissue and it's stored in the fat, and so you'll see the protocols involve a loading dose to get sort of load up the fat, and then you can reduce the frequency and dose of administration sometimes, and then it's sort of leaked out, if you will, or diffuses out of the fat and continues to sustain the adrenolytic effect. It's metabolized by the liver, excreted in the bile and the urine. It's an inducer of hepatic cytochrome P450, and therefore can affect the effect of other drugs or the metabolism of other drugs. It's induction with this drug can actually, by taking glucocorticoids away very quickly, particularly if you are you're treating a diabetic animal, you can see hypoglycemia if you don't react to lower the insulin dose quickly enough. As a result, the loading period is sometimes extended, so it makes it easier to keep up with their falling insulin requirements in these animals. So let's talk about how we start with OP prime DDD, and we're going to talk first about the loading dose. So we call this a loading dose. And what we do is for a period of 7 to 10 days, sometimes it's extended when you want to avoid that hypoglycemic effect to maybe 14 or even 21 days, and sometimes lower dosages. You start loading the animal, you give it every day during this period of time, and you wait to see either till you finish and the animal does okay, or if there are clinical signs that are consistent with hypoglycemia or weakness or anything that you could consider to be consistent with adrenocortical deficiency, you stop. And then you either test the animal, which is the ideal, with an ACTH stimulation test, or you just proceed to go to a maintenance dose. This drug needs to be handled with caution, therefore you should wear gloves because it can affect you if you ingest it or anybody who's handling it, including the owners. The goal of this loading period is to reduce the capacity of the adrenal gland to respond to that excess ACTH that's occurring. Indeed, ACTH, as cortisol falls, will go up even higher, and you have to make sure that the ACTH isn't able to sort of select out. It selects the most resistant adrenocortical cells. And so what happens is if you inadequately maintain your suppression of the adrenal gland, these cells can take over, and they sometimes come back, and it's much harder to get reinduce remission. So what do you see during treatment that might be consistent with glucocorticoid deficiency? Lethargy, weakness, vomiting, anorexia, all those things that we ascribe to sort of like Addison's disease. Let's just say that. It's like Addison's disease. And these are most commonly seen during the loading period, but also can be seen at any time you give the day of the dose. And so sometimes you can reduce these by dividing the dose. You can reduce the side effects. And in some animals, maintenance therapy, during maintenance therapy, and this may be counterintuitive to think about it, in order to sustain the suppression on the adrenal gland, you may need to supplement that animal a little bit with replacement glucocorticoids that allows you to eliminate some of the adverse effects of the drug. And why is this okay? It's okay because, remember, you're putting the animal, you're trying to push the animal's adrenal gland response to ACTH down to almost zero. And by supplementing an exogenous glucocorticoid in replacement amounts, you're not going to reinduce signs of hyperadrenocorticism. So how do we best monitor this therapy? It's basically you test for that adrenal reserve, and you do that with an ACTH stimulation test. Basically, at a periodic interval, have the animal come in, have them be dosed at their appropriate time, take a sample for cortisol, administer ACTH, usually IV or IM, and then you should be looking for a baseline cortisol level once you get the results back that would be in the lower limit of normal. It's okay if it's normal range, but most importantly is the post-ACTH cortisol should be flat, should not show much response at all, because if it shows any response, it suggests that those are cells that are the resistant cells. And if you see this, you can give the same dose and continue monitoring over increasing intervals. If you find that you have not either loaded the animal successfully or find the animal's signs coming back, you need to redo an ACTH stimulation test. And if you confirm an exaggerated response again, and we say a normal or exaggerated, normal would be, let's say, a twofold increase, and an exaggerated would be, sometimes 2 to 4-fold increase. Then you know you're not succeeding, and you need to go back to sort of reload the animal with daily therapy, and the dog is then retested at 5-day intervals until the desired response for the ACTH stimulation test is obtained. So I think it's worth sort of going back to our physiology just to see basically what we're doing. So remember, the problem we think occurs with pituitary-dependent hyperadrenocorticism, PDH, we think occurs somewhere in here in terms of the sensitivity to negative feedback, either one of these levels being altered. But the point is that ACTH is very, very high, and we're not doing anything to change that. So ACTH is very, very high. And as a result, we have enlargement of the adrenal glands, usually bilaterally. And so what happens with this drug, OP prime DDD, we're basically taking out the adrenal gland, the cortexes, and that will lead to ACTH going even higher. And so the tendency, so it goes even higher after treatment. And that means that any cells that are left in the adrenal gland that can respond will respond. And so that's why we try to sustain this treatment of the end organ very effectively to rule out any response to ACTH. Because if the pharmacological response to ACTH is nil, the endogenous response is likely also nil. So in this graph, kind of want to illustrate this. And this was borrowed from a paper from Mark Peterson. With successful therapy, if you measure ACTH, it should be high. So you can see here where ACTH is high. So we're saying that's high. And cortisol should be around, this is around the low end of the basal. That's a successful treatment. And that's what, and then when you give ACTH exogenously, you see very little response. And that suggests that sort of almost flat response is what we're looking for. So we avoid allowing those more drug-resistant adrenal cortical cells to start their recovery and growth. So as I said before, if you see the ACTH test being exaggerated, you should undergo loading again, and usually the protocol is somewhere between 3, 5, or 10 days. And then sometimes you need to increase the maintenance dose by as much as 50% to achieve the desired response. So you sort of go back to square one, reload the animal, usually for a shorter period of time, get them back down again, and then say, okay, that previous dose of maintenance dose I was using, or even frequency, wasn't adequate enough for desired treatment response. And this, basically I want to remind you that you've created an animal that's glucocorticoid deficient, so you have to think about that animal needing replacement therapy. So here we go, we have an adrenal-lytic drug that we've given, and so anytime the animal does poorly, we even mentioned that sometimes on maintenance therapy you would consider giving glucocorticoid replacement dosages so they can tolerate that treatment a little bit better. But certainly the animal needs to be supplemented when you have moderate or severe stress. And to remind you, when you take an animal to surgery, you have a situation where that animal would normally respond regardless of the type of surgery or even just anesthesia, for a week with the cortisol increasing. And so we need to play Mother Nature and try to anticipate this. And yes, you say, well, it's not going to lead them to heal. That's not exactly the case if you use relatively short treatment to get them over the major stress and then wean them quickly. Long-term monitoring of OP prime DDD, basically you can monitor them after loading successfully and then check them at 3 months. The ideal is to do, of course, examine them, do a CBC, chemical profile for the sodium potassium in case it's out of whack, but definitely the ACTH stimulation test. If these tests are okay, you can move to twice a year evaluation. In this schematic, basically I wanted to show you, if this is the upper limit of normal, here for cortisol, let's say, in micrograms per deciliter, you would see an animal with pituitary-dependent hyperadrenocorticism show an increased cortisol past roughly twofold above baseline. An animal with ability to, that's what we call euadrenal or normal response, is going to be above that too, so usually 2 to 4, and then a hypoadrenal, we'd like the goal to be no response. And so this is how we interpret also whether the animal is adequately controlled with Lysodren or not. And remember, the goal, this is not our goal. This is not our goal, is to be so euadrenal, if you will, because we know those resistant adrenal cortical cells exist, and we really want to suppress them. So this is our goal right here. In this figure, we can show how dogs can have a very dramatic response sometimes to the treatment with OP prime DDD, where they show the bilateral symmetrical alopecia here on the left-hand side, and dramatic and even almost a little overgrowth of hair, and even a change of hair color, lightening, can occur in some animals. It can be quite dramatic. So in summary, OP prime DDD is an older drug, a derivative of DDT, and it works by inducing necrosis of the adrenal cortical zones that make glucocorticoids and sex steroids. Because of this necrotic effect, it's preferred with adrenal cancers, particularly metastatic carcinomas. Its side effects are largely due to glucocorticoid deficiency, and therefore sometimes it's necessary to give glucocorticoids simultaneously with the treatment. We know that inadequate treatment and monitoring regimens may lead to a recovery due to the massive stimulation by endogenous ACTH of cells that are OP prime DDD resistant. And therefore, ideal monitoring protocols involve periodic exogenous ACTH, adrenocorticotropic hormone, stimulation tests.